we have Dr. Nirmal George Nainan, who is a consultant pediatrician and neonatologist at Muthoot Healthcare Coventry as the moderator for this session. He did his graduation from Jubilee Mission Medical College and from Pushpagiri Medical College and post-graduation from Jubilee Mission Medical College. Welcome, sir, to this meeting. And I would also like to invite Dr. Megha, who is a DNB Family Medicine resident at Muthoot Healthcare Coventry, for doing the case presentation for today. Over to the chairperson and the presenter. Thank you.
Yeah, thank you. Good evening, all. Thank you for having me. At the onset, let me thank the AFPI for having me moderate the session. I truly consider it a privilege to be among you. I don't intend to keep you long because I'm sure that everyone hearing me has seen, examined, investigated, and managed a case of diarrhea. So with that, but let's see how, because you tend to get this in your examinations as well. So let's see how to handle a case. Okay, a very straightforward case. So when Dr. Megha is ready, we'll start with the case presentation.
Megha, you are not audible. Can you? Megha, can you please unmute yourself? Yeah, I think you can start now.
Am I audible, sir?
Yes, you are audible.
Good evening, all. Myself, Dr. Megha, DNB Resident Family Medicine, Muthoot Healthcare, Coventry. Starting the case presentation.
Yes, Megha, please go ahead.
One-year, 2-month-old female child coming from Pattanathitta. Mother is the informant and information is reliable. Date of admission is 21st June 2024 and date of examination 22nd June 2024. Coming to the presenting complaints.
Yeah, so before coming to the presenting complaint, Megha, I would like to know when do you call an information to be reliable and complete?
The mother is staying with the child.
Yes.
And the mother is educated. She is a BCom graduate.
Okay.
Right?
Okay. Yeah, so
and
basically you need a person who is being staying with the child and who has known the child since the present illness at least. Okay. And that person should be of a sound mind, right?
Okay.
Okay. Yeah, go ahead, please.
Coming to the presenting complaints, vomiting for 4 days, loose stools for 1 day, and fever for 1 day. Now, history of presenting complaints. The child was apparently normal 4 days prior, following which she developed vomiting. Child had 2 episodes of vomiting 4 days ago. Vomitus contained food particles, was non-bilious and non-bloodstained. She was treated from nearby hospital and vomiting subsided with medication. Child then again presented with 2 episodes of vomiting since 1 day. Vomitus was non-bilious, non-bloodstained and was not relieved with oral medication. And child had loose stools since 1 day, 2 episodes of loose stools in a day. It was watery, small volume stools, yellowish in color and non-foul smelling. No history of blood or mucus in stool and no history of crying on defecation. There was history of food intake from outside 1 day back and loose stool started about 12 hours after food intake. Child had history of low-grade fever 1 day ago, which was relieved on medication. The fever was not associated with chills or rigor or skin rashes. No history of decreased urine output, no history of cough, nasal discharge or nasal block, no history of crying while urination, no history of contact with fever, and no history of recent vaccination. During the hospital stay, child had multiple episodes of loose stools. On second day of admission, patient had 3 episodes loose stools. On third day, 3 episodes of loose stools and 1 episode of vomiting. And on day 4, 5, and 6, child had 1 episode of vomiting. Vomitus was non-bilious, non-bloodstained. Loose stools was watery, non-bloodstained. Now, the frequency of loose stools decreased and consistency had become semi-solid.
Okay. Okay,
Coming
so
to the
okay. So before we go to the past history, so what do you think? Are you dealing with an acute problem here or a chronic problem?
acute problems.
Yeah, because it's only a span of days, right? Can you just go
Yes.
to your presenting complaint, please?
Sorry, sir.
Can you go back to your slide with the presenting complaint?
Presenting complaint is vomiting for 4 days, loose stools for 1 day, and fever for 1 day.
Fine. Okay, so you have an acute problem of vomiting, loose stools, and fever. So hearing the complaint itself, I think you can make a few diagnoses, right? A few
Yes, sir.
DDs can come to your mind, right?
Yes.
Okay. Can you on the top of your mind, can you name some DDs?
DDs could be acute diarrheal disease,
Fine.
urinary tract infection,
All right.
appendicitis.
Okay, I give you that. Okay. Fine. So we have made few DDs, right? Okay. So let's go to your history of presenting illness, and we'll see all the symptoms one by one, right?
Okay.
Okay. So now you have vomiting, which is acute in onset, and you said that it is subsiding on medication. Okay. And vomitus was non-bilious. Okay. And what about the loose stools? Come to the loose stools, please.
Loose stools. Initially, it was 2 episodes of loose stools in a day. It was watery, small volume stools, yellowish in color, and non-foul smelling.
Okay. Okay. So how do you define diarrhea actually?
Diarrhea is increase in consistency or frequency of stools in a day.
Okay.
More
Any
than
other?
3 episodes of
Yeah.
loose stools in a day.
Yeah. Any other definition? Or when the normal bowel habit is altered. Okay. So there are 3 definitions. So what do you think? Is it the frequency that is more concerning, or is it the consistency that is more concerning regarding, if you want to call it a diarrhea?
Consistency.
Yeah, consistency is actually more in par with diarrhea. So any change of consistency is actually brings you more in line with diarrhea. So how to approach? So how do we clinically approach this? So first of all, you have to confirm diarrhea, which you have said that there is 2 episodes of loose stools and watery stools, right?
Yes, sir.
So do you think it's acute or chronic?
It is acute.
Acute. Okay. So acute, and how do you define a chronic diarrhea?
Chronic diarrhea is duration lasting for more than 14 days.
Fine. Okay. And what are the types of stool on the top of your head? You can classify types of stools.
Based on duration, diarrhea can be classified as acute diarrhea, persistent diarrhea, and chronic diarrhea.
No, I'm asking about the consistency of stools. So it can either be a watery stool, all right? It could be a fatty stool, right? Or it could be an exudative stool. Okay? Okay. When by exudative, what I mean is it could be blood-stained or mucus-stained. Right? So if in this case you have mentioned it is watery stools.
Watery stool.
Yeah. How do you again classify watery stools? So it could be either secretory stools or
osmotic
stools. Good. Okay. So it could either be a secretory or osmotic. If it is watery, what is the underlying pathology in the intestine? It is actually a motility issue. Okay. There is a hypermotility issue. So how do you classify again? Can you give me some examples of secretory diarrheas or osmotic diarrheas?
Osmotic diarrhea include lactose intolerance.
All right. Yeah. So basically something to do with the diet, right?
Yes.
Okay. Then
Secretory diarrhea related with infections,
Very good.
which causes a secretion of fluid into the gut.
Agreed. Agreed. What infections?
Like bacteria like cholera, E. coli.
Okay. Okay. Before that, you have to say viral infections, right?
Okay.
Yeah. Yeah. More common. More common. Yeah. Is there any other non-infective cause causing secretory diarrhea? You think beyond infections. Is there any tumors that can produce secretory diarrheas?
Malabsorption.
Okay, malabsorption. Fine. Malabsorption does not actually cause secretory diarrheas.
Endocrine causes.
Yeah. You're reaching somewhere.
Zollinger-Ellison syndrome.
So yeah, very good, very good. They are known as VIPomas. Okay. So secondary to malignancy as well. Okay, you have your lymphomas, leukemias that also can come with diarrheas. Okay, you mentioned about endocrine causes. Can you name one endocrine cause that causes hypermotility? One endocrine cause which actually increases, the sympathetic activity in all of the body, and as part of that, also it causes some hypermotility. So it is nothing but hyperthyroidism. Okay. Okay, hyperthyroidism. Okay. So these are when you get your stools to be watery, you should be thinking about some diseases other than infections as well. Okay.
Okay.
So watery can be divided into secretory and osmotic. So you have your secretory causes. You have told me your osmotic causes as well. Okay. Suppose the stools are fatty or greasy in nature. What will you think of?
Malabsorption.
Very good. Very good. Malabsorption. So the underlying cause could be a pancreatic or a biliary cause. Right? Okay. Is there any infection that can cause greasy, gray colored stools?
Steatorrhea.
A parasitic infection that can cause greasy, gray colored stools? It's called giardiasis. Okay.
Yeah.
Called giardiasis. Okay. Is there any other condition that you can think of, which causes repeated respiratory infections?
Yes. Cystic fibrosis.
Very good, very good. Yeah. Cystic fibrosis. So that can also present with a fatty or a greasy stool, right?
Okay.
And can you give me a few examples of exudative stools? And by exudative, I mean there is blood and mucus in stool.
Bacillary dysentery and amoebic dysentery.
Yeah. Yes. Then your inflammatory bowel diseases. Okay. Inflammatory bowel diseases. Yeah, I can see people in the chat box commenting. Very good. Inflammatory bowel disease. And your colitis. Okay. Colitis can also come with blood in stool. So these are some of the broad, ways to classify your loose stools. And to have some DDs is very, very important because you have to rule out one by one using your negative history. All right. Okay. So you have started ruling out. I have noticed a few negative histories. So can you tell me each negative history and what it meant and what did you mean to rule out?
No history of blood or mucus to rule out dysentery.
All right.
Then crying on defecation, also tenesmus and seen in dysentery.
Okay.
Then history of food intake from outside pointing to food poison related to toxins or other infections.
Okay. In fact, can you just go back one step? Yeah. In fact, that sentence that you have mentioned, that is history of food intake and loose stools started about 12 hours after food intake. So what does it actually imply?
Certain toxins causes immediate symptoms after food intake, like staphylococcal toxins.
Okay. More than staphylococcal?
Bacillus.
Yeah. Okay. You have your Shigella, right?
Yes.
Yeah, Bacillus cereus, yes. One of them has mentioned. Okay, fine. Okay, go ahead, please.
No history of decreased urine output to rule out dehydration,
Okay.
severe dehydration. Then no history of cough, nasal discharge, and nasal block, some other respiratory viral illnesses.
Okay, so what do you call those the kind of diarrheas where the primary pathology is not in the gut?
Parenteral diarrhea.
Very good. Can you name a few DDs, where you get parenteral diarrheas?
Seen in pneumonia,
Okay.
UTI,
Yes.
otitis media.
Very good. Also in meningitis. Okay. These are some of the few diseases. Okay, you have mentioned them. And how can I differentiate? Like I have a person with a primary gut problem presenting with fever and diarrhea. Okay. I have another person another child who has UTI. Say he has UTI. He also presents with fever and diarrhea. So how can I differentiate between them? From history, I mean, and from the cause of illness.
Presence of abdominal pain.
Okay. But diarrhea might also have abdominal pain, right? I mean, the primary diarrhea might also have an abdominal pain, right?
Presence of dysuria.
Okay.
While urination.
More than that, when the problem is primarily in the gut, the fever usually lasts only for maybe 1 or 2 days. Okay. But it's the diarrhea that continues. Okay, it's the diarrhea that continues beyond maybe 5 to 7 days or 7 to 10 days. Okay. But when it's a parenteral diarrhea, so when the primary problem is not in the gut, you find that the diarrhea lasts only for maybe 1 or 2 days. Right, the diarrhea is short-lived as compared to the fever. Okay, the fever, unless you correct the underlying cause, the fever does not subside.
Sorry.
Okay, so that is how you differentiate between from the history, I mean. Okay.
Okay.
All right. Okay, please go forward.
No history of complicated fever and no history of recent vaccination.
Okay.
Then in the hospital stay, child had developed multiple episodes of loose stools and vomiting.
Yeah. Okay. So you have mentioned the cause in hospital, right?
Okay. Yes, sir.
So it's always good to mention where the child was admitted in the hospital, whether he was admitted in the ward, whether he was admitted in the ICU. Okay. So that gives an impression of how sick the child was. Okay. Yeah.
The child was admitted in the ward.
Yeah. Tell me. Go.
The child was admitted in the ward.
Okay. So from what I basically want to imply is that from the history itself, you should get an idea of the cause of the diarrhea, right?
Okay.
The severity of the diarrhea. All right. And how long did it take to resolve?
Yeah.
Okay. And how was the child during discharge? Okay. So these are some of the things from history itself that you can highlight and you can confirm it with your examination findings. All right. Okay. So yeah, go ahead, please.
And during the hospital stay, the frequency of loose stools has finally decreased and the consistency had become semi-solid.
Okay. So fine. After how many days of admission was that?
After day 5, about 5 days of admission.
5 days of admission. Okay. So how do you classify between small bowel and large bowel diarrheas?
Small bowel and large bowel diarrheas are on the basis of the volume of stool. Large volume stool is usually seen in small bowel diarrhea.
Okay.
And the pain on defecation is usually absent in small bowel diarrhea. And in small bowel diarrhea, usually there may be associated symptoms like vomiting. And dehydration is more common in small bowel diarrhea. Okay.
So basically, your small bowel diarrheas will be large volume diarrheas. Okay.
Yes.
And watery diarrheas compared to your large intestine. Okay. Why is that? Simply, majority of the water absorption takes place in the small intestine. Okay. In the 80% of your water absorption takes place in the small intestine, and the 20% only goes to the Large intestine. Okay. Okay, fine. And if the vomitus is, or if the loose stools are bilious, green colored stools, what do you mean?
Malabsorption.
Supposing that this is okay, in this case it's a 1 year old, 1 year and 2 month old girl child. So supposing if it was a 3 month old child who had greenish stools, what would be your inference? So when does the stool turn green? Why does the stool turn green? Because of what? Presence of what in the stool?
Bile.
Very good, bile. So what is the function of bile?
Fat absorption.
Fat absorption, right? So if the child is underfed, okay, the child underfed, that is if the feeding is not proper. In a 3 month old child, if the feeding is not proper. For example, you might have heard mothers who say that their breast milk is inadequate. If they feed the child only for a short while, the child only gets the fore milk, and fore milk is 80% water.
Okay.
There is nothing for the bile to act on. Okay. Bile needs fat to act on, fat for absorption. So once if the child does not get the hind milk, there is no fat. So what does the bile do? Bile has no function but to go in stool. Okay, so that way you can get a greenish stool. Okay, fine. Okay, let's move forward.
Now coming to the past history, there was no history of similar illness in the past and no history of previous hospital admissions.
Okay.
Coming to
So you
antenatal.
need to say that there is not a chronic illness. This is just a well child who has been brought with an acute illness. Okay.
And coming to the antenatal history, first trimester.
Is there any relevant things in the antenatal history?
No, the antenatal history was uneventful.
Okay, then we can skip. Okay.
Birth history, full-term normal delivery, birth weight was 2.800 kilograms. Postnatal history, baby cried soon after birth, no respiratory distress, and no resuscitative measures were required. Breastfeeding was initiated within 1 hour of delivery, and the baby passed urine and meconium within 24 hours. And there was history of NICU admission for 1 day for phototherapy.
Right. Okay.
And coming to immunization history, child is immunized till date as per national immunization schedule, and the last immunization taken was at 9 months. BCG scar seen on left upper arm. No history of adverse events following vaccination, and optional vaccinations were not taken. Okay,
so to all the PGs out there, I would advise you to learn the national immunization schedule and the IAP schedule. Okay, the recent ones before you go for your examination. Okay, the National Immunization Government of India has released the latest one in 2024, and also the IAP has released the recent one in 2024. So actually, the concept of optional vaccination is actually going out. Okay, you either take the National Immunization schedule or you take the IAP schedule. Okay, but I would like to know what vaccinations you would have stressed upon, whether the child has taken that or not.
Rotavirus vaccine.
Okay.
Pneumococcal.
Okay. Yeah, more of an optional vaccine. Yeah, more an IAP vaccination. Yeah.
Typhoid vaccine.
Very good. When is typhoid vaccine being given now, according to latest IAP?
2 years.
No, not in 2 years. 7 months.
9 months.
Yeah, 7 months. 7 months. Yeah, and then any other optional vaccine or not vaccine? IAP vaccine.
Hepatitis A vaccine.
Very good. When is it being given?
6 months and 9 months.
No. So the first vaccination is given at 12 months.
12.
Second dose is given at 18 months. Okay, 6 months apart. Okay, yeah. So you need to know about these vaccinations. Okay, in detail. Okay, yeah. Please go ahead.
Developmental history, gross motor milestones, neck holding was attained at rolling over at 5 months, sitting without support at 8 months, stands with support at 9 months, creeps well and stands without support at 12 months.
Okay.
Fine motor, grasp at 9 months, key social and adaptive milestone, waves bye-bye by 9 months and comes when called at 12 months. Coming to key language milestones, bisyllables at 9 months and 1 to 2 words with meaning at 12 months.
Okay, so now the child is 14 months, right?
Yes, sir.
Yeah, so what do you expect a 14-month-old child to do in all these developmental areas?
In key language milestone, speaking of 1 to 2 words, then
Okay.
walking with support,
No, 14-month-old child?
walk without support.
Yeah, walk
Walks
independently.
well.
Okay, walk independently. Okay, yeah.
Then grasp, mature pincer grasp,
Okay,
and comes when called.
sure. Okay.
Then coming to dietary history, child was exclusively breastfed for 6 months. Complementary feed started at 6th month with ragi. Family diet started at 9th month, and breastfeeding is still continuing.
Okay.
This is a diet chart. Child is getting 544 kilocalorie and 15.2 gram protein respectively. Comparing to ICMR 2010 recommendation, required calorie is 720 kilocalorie and there is a calorie deficit of 176 kilocalorie and the protein is required protein is 15.21 grams.
Okay. So suppose that the diarrhea had started while the child was while the child was being introduced on new feeds after 6 months. What would be your differential? The child was exclusively breastfed till 6 months. And after 6 months, the child had been introduced on some additional food items, right? And that is when the child started getting non-stop diarrhea.
Cow milk protein allergy, if cow milk is introduced. Wheat.
Yeah. Wheat is
celiac disease.
very
Celiac
good.
disease.
You have to think about conditions like celiac disease, malabsorption conditions like celiac disease. Okay, sure. Okay, go ahead.
Coming to family history, no history of similar illness in the family. She is a first order child of non-consanguineous marriage. No history of TB, asthma, thyroid disorders in the family.
Okay. Good to see that you have managed to draw the pedigree chart. Okay, you have to always, because the examiner will be looking for this pedigree chart in the family history. Okay.
Yes.
Okay. And how many generations should you draw?
Three generations.
3 generations. Yeah. Okay. Right.
Now coming to socioeconomic history, belongs to upper middle socioeconomic class according to modified Kuppuswamy socioeconomic scale. The house is terraced house with proper sanitation and ventilation and source of drinking water as well. There is no overcrowding and is using firewood and LPG for cooking.
Okay. So when was the modified Kuppuswamy scale last modified?
2019.
Yeah. And what is the difference between the early Kuppuswamy and the present Kuppuswamy?
Including of income.
Yes. So the early Kuppuswamy took into account only the income of the head of the family, right? Okay. So the present ones, actually take up the income of all of the family members. Yeah. But when dealing with the case of diarrhea, you have to, as you have rightly written, you have to write about the proper sanitation measures. Okay, whether it's a toilet, whether there is overcrowding, the source of well, and if it has been sanitized or chlorinized. Okay. And you have to mention about all that. Okay. Fine.
Now coming to the summary. 1 year, 2-month-old female child born out of non-consanguineous marriage, belonging to upper middle socioeconomic class, delivered at 38 weeks of gestation via normal delivery with a birth weight of 2.8 kilogram, exclusively breastfed up to 6 months, immunized till day, normally developed child with nutritional deficiency suggestive of calorie deficit of 76 kilocalorie, now presented with complaints of multiple episodes of vomiting, loose stool, and history of fever for 1 day.
Okay. Okay. So after a full history, what is your reading? Again.
Acute diarrheal disease.
All right.
May also be urinary tract infection.
Okay.
Uh,
Okay. Fine. Let's go for it. Can it be acute bacillary dysentery? The sudden onset of symptoms after having.
But there was no history of blood or mucus in the stools.
Okay.
Or history of crying while defecation.
Okay. Okay. So suppose if the child had an abdominal distension along with this diarrhea, what other DDs would you think
of? Paralytic ileus, which can occur as a complication of this diarrhea.
Okay. Okay. Suppose an 8-month-old or a 10-month-old child has come with diarrhea along with abdominal distension, irritable cry, frequent episodes of vomiting.
Could be intussusception.
Very good. Very good. It could be an acute intussusception, or it could be a complication of diarrhea, right?
Okay.
Which you have mentioned. One is paralytic ileus. Second one. Sepsis. Okay.
Okay.
Yeah, sepsis. And third, paralytic ileus mainly due to what imbalance?
Electrolyte imbalance, potassium.
Yeah, potassium.
Low
Hypokalemia.
potassium.
Yeah, hypokalemia. Okay, fine.
Now coming to general examination. Child is restless and irritable. No pallor, icterus, cyanosis, clubbing, lymphadenopathy or edema. Vitals, pulses 124 per minute, regular, normal volume, character. All peripheral pulses equal and bilaterally palpable, and no radiofemoral delay. Respiratory rate 30 per minute, abdominothoracic. Temperature 98.6 degree Fahrenheit. Saturation 99% on room air. Blood pressure 90/60 millimeter mercury in right arm sitting position. And capillary refilling time is less than 3 seconds.
Okay. Okay, can you just go back to the vitals? Yeah. So, in what condition will you expect the heart rate to rise?
In severe dehydration.
Okay.
And high. And high grade fever.
Okay, child is going for a shock. In diarrhea, what happens is there can be hypovolemic shock. Okay, hypovolemic shock. Okay, so there can be initial phase, there can be tachycardia and hypotension as well, and rapid breathing. Okay.
Okay.
So that will be the change of vitals. Okay, go to the next slide, please. Okay. You mentioned that the general condition of the child is irritable, right?
Yes, sir.
What do you imply by that?
To assess dehydration.
Okay, so how do you assess dehydration?
Assessing the dehydration by looking for the general condition of the patient and looking the eyes, oral cavity, and skin pinching, skin turgor.
Okay. And also the ability to drink water.
Water.
Okay. Yeah. Okay. So how do you? Okay. Go for it.
Coming to head to foot examination, head is normal size and shape. Anterior fontanelle closed. Scalp hair is normal. Face no dysmorphism. Eyes normal. Nose squint. Ptosis. No signs of vitamin deficiency.
Okay, what signs of vitamin deficiency do you see in the eye?
Vitamin A deficiency.
Yeah.
Okay. There can be bitose spot.
Okay. So you should know about the classification of vitamin A deficiency. Okay.
Okay.
Okay. Yeah. Okay. Go ahead, please.
Then no nasal discharge, no nasal flaring. Ears, preauricular and postauricular region was normal. No tag, sinus, pits, no tracheal tenderness, no mastoid tenderness. External auditory canal appears normal.
Okay.
Oral cavity, good oral hygiene. Oral cavity is dry. Tongue and lips are also dry. Uvula central. Tonsil and pharyngeal wall normal. No gum hypertrophy. No mucosal bleeding or lesion.
Okay.
Neck normal. No webbing. No palpable swelling. Chest symmetrical. No chest retractions. Spine normal. Upper limb and lower limb. No deformities noted. Nails normal. Fingers normal in number and shape. Normal skin turgor.
Okay. Okay. So your skin turgor is normal. Okay.
No.
Okay. Fine.
Now
Okay.
coming to
So how do you classify this? So you have examined the child from head to foot, right?
okay, yes, sir.
Okay. Yeah. So what do you think where the dehydration lies? I know that you had mentioned the oral cavity as dry and the lips also dry.
And
Yeah. But the skin turgor is normal.
Skin tone is normal. There is some dehydration because child is
Some dehydration.
restless.
How about the eyes?
Sir,
How about the eyes? Are they sunken or not?
no, eyes was not sunken.
Okay. Okay. So there are few symptoms, maybe in the some dehydration part and some symptoms are the no dehydration part, right?
Yes,
So,
sir.
so if more than 2 or more symptoms are there, it's better to be put in the some
Some
dehydration.
dehydration.
Yeah, yeah, okay, okay, go ahead. But always remember that the eye, looking for sunkening of eyes, those are all subjective. It can vary from person to person.
Yes, sir.
But what you should not miss is the skin. Okay, you should know how to examine the skin turgor. Yeah, sure. Go ahead.
Now coming to anthropometry. The weight of the child is 9 kilograms. Expected weight is 10 kilograms. And there is it is normal. And height is 73 centimeter. Expected is 75 centimeter. There is no stunting. Then head circumference is 45 centimeter, which is normal. And mid-arm circumference is 14 centimeter, also normal.
Okay, okay, fine. So you have a appropriately well for each child. Okay.
Okay. For developmental assessment, milestones has been achieved as per age. At present, child walks, mature pincer grasp is present, comes when called, and speak 1 to 2 words with meaning. Now coming to systemic examination, upper GIT, good oral hygiene, no ulcers, tongue and lips appears dry. And on inspection, shape of abdomen appears normal. All quadrants move equally with respiration. Skin over the abdomen is normal. Umbilicus central and everted. No dilated veins, scars, pulsations or peristalsis. On palpation, no local rise of temperature, no tenderness. Abdomen is soft, normal skin turgor, no palpable mass and no organomegaly.
Okay.
On percussion, a resonant note heard over abdomen. And on auscultation, normal bowel sounds heard.
Okay.
External genitalia and hernial orifices appear normal.
Okay. So your primary GI is over. So this is a primary GI case. Okay. So, but what will you be checking in the other systems?
Other system exam.
Yeah. So we had few DDs pertaining to each of the systems, right?
Yes.
Yeah.
Other system examination, respiratory system was normal. Normal vesicular breath sounds heard. No added sound.
Okay.
No retractions.
Okay.
Then on cardiovascular system, first and second heart sounds heard. No murmurs.
Yeah.
And
so
on
in the system, what can go wrong if the child is severely dehydrated?
there can be tachycardia, hypotension,
Yeah.
weak thready pulses.
Very good. The child can go for
Shock.
cardiac failure. And what will happen in cardiac failure? What will happen to the heart sounds in cardiac failure?
Third heart, S3.
Okay, that can be S3 gallop. Okay, agree. But to the S1, so the S1 will be soft. Okay, there will be a soft. Soft test. Okay. Okay. Okay, fine. Go ahead, please.
Summary: 1 year, 2-month-old female child born out of non-consanguineous marriage belonging to upper middle socioeconomic class, delivered at 38 weeks of gestation via normal delivery with a birth weight of 2.8 kg, exclusively breastfed up to 6 months, immunized till date, normally developed child with nutritional deficiency suggestive of caloric deficit of 176 kilocalorie, now presented with complaints of multiple episodes of loose stools and history of fever for 1 day. On examination, child was found to be irritable, restless, and with dry oral cavity. Vitals were stable, and systemic examination were within normal limits.
Okay. Okay.
The probable diagnosis could be acute diarrheal disease with some dehydration, fully immunized child up to age.
Fully immunized child up to age with no PEM or standing, right?
No standing.
Yeah. So how will you proceed further?
The child is having acute diarrheal disease with some dehydration. So the treatment is treatment plan B. The
Okay.
child needs to be hospitalized and should be monitored.
Yes.
And rehydration with ORS.
Okay. So how do you give ORS according to plan B?
According to plan B, ORS replacement of 75 ml per kg over 4 hours, and then reassess.
Yeah.
If again there is some dehydration, ORS is repeated one more time.
Okay. Or if the dehydration has come down, you switch to?
Plan A.
Or if the dehydration has worsened, you switch to?
Plan C.
Okay. So so now we have hit the topic of ORS, right?
Yes.
So what kind of ORS do we use now?
WHO low osmolarity ORS.
Very good. Low osmolarity ORS. Okay. So you should be knowing the combination or the contents of WHO ORS. Okay. Can you tell that?
Contains sodium 75 millimole.
Okay.
Glucose also 75 millimole per liter. Chloride 65. Potassium 20. And citrate of 10 millimole per liter.
Okay. Okay. So what is the mechanism of ORS?
This ORS causes reduce stool output and decreases in vomiting.
Okay. What is the mechanism of action?
There is a glucose.
So there is sodium and glucose, right?
Glucose.
Yeah. So how does it act on the intestine? Yeah. How does it help to reduce the perserate in diarrhea?
The glucose, there is glucose dependent transport. The glucose
Yes.
takes sodium and water.
It is actually the SGLT, right? Sodium glucose transporter, which is present in the intestine, small intestine. Okay. Yeah, it has seen that with 1 mole of glucose or 1 mole of sodium, 1 mole of glucose is also taken in.
Yeah.
Okay. So that's the mechanism of action of ORS. What is the action of citrate in the ORS? You mentioned that there is citrate 10 moles, right? 10 millimoles, right? Anybody? Role of citrate in ORS? Why is the citrate there? There's nothing but to increase the shelf life. Okay. Shelf. Yeah. But one of them has mentioned also gives bicarbonate. I agree with that. Okay. What is super ORS? So these are some of the questions that the examiner can ask you. What is super ORS?
Super ORS is cereal based or rice based ORS.
Yeah. So in normal ORS or the WHO ORS, what you have is a monosugar like glucose, right? Yeah. So in some cases there will be maldigestion. Okay. What is maldigestion? See, for any carbohydrate to be absorbed, it has to be broken down into monosaccharide. Right? So, and for any protein to be absorbed, it has to be broken down into amino acids. Only then can it be absorbed. Right? So, there might be some cases causing maldigestion. In that cases, you can give ORS. Okay, ORS. Okay, but what happens in super ORS? You are supplementing rice with or a cereal with ORS. Okay, which is basically given in
Cholera.
cholera. Very good, very good. It is basically given in cholera. It helps to decrease the purge rate.
Right.
What is super ORS?
The addition of zinc to this super
Very,
ORS.
very good, very good. Addition of zinc to super ORS is super ORS. Okay, again, what is the dose of zinc that you give in diarrhea?
More than 6 months, it is 20 milligram elemental zinc per day. Less
Sorry,
than
please repeat that again.
more than 6 months, 20 milligram of zinc.
Okay.
Less than 6 months, 10 milligram of zinc per day for
Per-
14 days.
14 days. Why do you give it for 14 days? Or what is the action of zinc?
Zinc reduces the further episodes and reduces the severity.
Okay. It also helps in replenishing or recycling or rebuilding the enterocytes. Okay,
Okay.
enterocytes. Okay. Yeah, mucosal healing. Yeah. Okay. So plan B, you have given plan B. Okay. So do you give antibiotics to this child?
No.
Okay. So next question automatically comes. What are the indications that when you give antibiotics in diarrhea?
Antibiotics are given for dysentery if there is blood or mucus in the stool,
Okay.
or it is a case of cholera.
Okay.
Then children with severe acute malnutrition.
Very good. Yeah.
Then if sepsis is there.
Agreed. So what are the organisms that can cause dysentery?
Shigella, Salmonella.
Okay.
Then and E. coli, enterotoxigenic and enterohemorrhagic E. coli.
Okay. So what kind of so enterotoxic E. coli, how does it produce? So basically there is a toxin that is released, right? Enterotoxic E. coli. So that will present as watery diarrhea. Okay. And what about entero-invasive? There's something known as entero-invasive E. coli. Yeah. So that will invade the mucosa and present as bloody diarrhea. Okay. Diarrhea with mucus and blood. Yes. Yeah. So one of the person has asked, should we give zinc to all the ADD cases? Yes. See, as per guidelines, we should give it to all the ADD cases. Yeah. But truly speaking, it is actually meant for malnourished children. Okay. Malnourished children. Truly speaking, it is given. It is only meant for zinc is meant for malnourished children. But to follow guidelines, we have to give zinc. However, in the examination, when the examiner asks you what drugs do you give for treating diarrhea, your answer should be first one is
rehydration, ORS.
ORS. Second one is
Zinc.
What do you know about Resomal?
Resomal is ORS given for severe malnourished children.
Okay.
That is rehydration solution for the severely malnourished children.
Okay. So how is it different from the usual ORS, WHO ORS?
It is low sodium.
Yes.
And high potassium.
High potassium. Yeah. High potassium. How many milliequivalents?
40 milliequivalent potassium.
40 milliequivalents of potassium. Whereas in your WHO ORS, you have only
20 milliequivalents of potassium.
20 milliequivalents of potassium. Okay. So we have touched upon the treatment first. So I'll finish that. So what do you do in plan A?
In plan A, the child can be treated in the home itself.
Okay.
With ORS.
Okay. So how do you expect the mother to give ORS? So how do you prepare ORS actually?
That ORS packet, if ORS packet is available, one packet is can be mixed with about 200 ml of water.
One packet is mixed with?
1 glass of water, 200, about 200 ml.
How do you make ORS solution? Okay, you don't get the solution as such, right? You get a packet, right?
Yeah.
You get a packet of ORS powder, right? So how do you make it into an ORS solution? That's my question.
In 1 liter of water,
Yeah. Now we're getting that. Okay. Yeah. You should mix it with 1 liter of
1 liter of water.
boiled and cooled water. And should you keep it in the fridge or outside?
Outside.
Outside, yeah, where there is no direct sunlight. And for how long can you use an ORS that you have reconstituted?
About 24 hours.
Yeah, for 24 hours you can use it. Okay, if anything is left beyond 24 hours, you throw it out. Okay. Okay, so and how do you advise the mother to give ORS to the child?
ORS should be given following every purge, and it should be given in sips. Should not be given as whole.
Yeah. So the idea is to, the other way is to sip it as you drink tea, a hot tea, right? You have to sip it, and not like you drink water. You do not gulp down the ORS. Okay. You sip in and take the ORS. Yeah. What happens if you drink it like how you drink water?
There are chances for vomiting.
Yeah. So that's a chance for intolerance. Okay.
Yeah.
Okay. Then how can you give? Yours is a child of 1 year and 2 months old, right?
Yes.
So how will we give ORS to this child?
About 50 to 100 ml for every purge.
Every purge, yes, every purge. And you have to offer it in gaps of
1 to 2 minutes.
10 minutes. 10 minutes. Okay. You have to offer a gap of 10 minutes. Okay. That is if the child is having no dehydration. Right? Yeah. The child has some dehydration. So you give it in a dose of 75
ml per kilogram.
4 hours for 4 hours. Okay. And how do you How do you proceed if the child is having severe dehydration?
Severe dehydration, the child should be admitted and should be treated with IV fluids.
Yeah, you should treat it with IV fluids. So what is the first choice of fluid that we use usually?
Ringer lactate.
Yeah. So some books say it is normal saline, but usually in practice we give ringer lactate. Okay. And can you tell me how the dose? Because in pediatrics everything is weight related, dose related. So you have to tell me the dose also.
100 ml per kg is given over 6 hours if the child is less than 1 year. And in that 30 ml per kg should be given in the first hour, and the rest 70 ml per kg over next 5 hours. And if the child is more than 1 year, 30 ml per kg given in half an hour, and 70 ml per kg given over next 2.5 hours.
Okay. So now I'll ask you about a few investigations that we usually do in acute diarrheal disease, and you have to tell me your opinion or what do you think about it. Okay. First, coming to, you all know that we usually send stool routine, right?
Yes, sir.
So what do you look for in a stool microscopy? How useful is the stool microscopy in acute diarrheal disease?
To look for any ova, cyst, consistency of the stool, then presence of RBC.
The only practical importance of stool microscopy is to look in the hanging drop. What do you use the hanging drop for?
For cholera, Vibrio cholera.
To diagnose cholera. Okay, so that is the main reason for looking for a stool microscopy. And you find you must have also seen your consultant sending for reducing substances, stool for reducing substances, right?
Yes.
Yeah. So what if a stool reducing substance comes as 1+?
Could be secretory diarrhea, like osmotic lactose intolerance.
Lactose intolerance is a very broad term. Is it primary or secondary?
Secondary
lactose
Secondary
intolerance.
lactose.
Okay. So we usually say that accompanying most of the viral diarrheas, there is some sort of transient secondary lactose intolerance, okay, which is self-limiting. Okay.
Okay.
So unless and until there is, what will happen if there is, an imminent or a very major lactose intolerance? So how will the stools be?
It will be explosive diarrhea.
Very good. Explosive diarrhea. That is, there will be a flatulence. Okay.
Flatulence.
Yeah, and anything around the perianal.
There will be perianal excoriation.
Yeah. Perianal excoriation. Yeah. So only then has it to be given the due importance it has to, unless and until then, if the child is well, other than the diarrhea, the child is well, it need not be taken much into consideration. Okay. What about yeast? If you find yeast in a stool routine or a stool microscopy?
Yeast. Yeast is usually seen in immunocompromised or malnourished.
Actually, yeast is a common finding. Okay. This is a common finding. Okay. And someone has mentioned antibiotic administration. Very good. That also. Okay. That also happens when you give prolonged antibiotics. Okay. What happens when you see a fat globule in stool?
Malabsorption.
Malabsorption. So if you see a fat globule in stool, every case is a malabsorption. See, fat globule in stool usually has an importance only if the child is malnourished. Okay. If the weight, the height are all below the third centile, the child's growth is not appropriate for his age, then you see a fat globule in stool, you go ahead with a fat challenge test. Okay. If the child is normal, as in this case, the child's growth is along in line with his age, and even if you see a fat globule, it might be a normal finding. Okay. What about stool culture? You must have seen many stool cultures, I can assume. Okay. And most of the stool culture will grow E. coli, right?
Yes.
Yeah. So what do you have to say about that?
Stool culture is usually done if dysentery is suspected.
Okay. So an E. coli growth in stool culture has to be taken as normal. Is that what you are?
It is normal.
Yeah, actually, stool culture has not at all a good role in determining your treatment. Okay. E. coli growth is perfectly normal. Is a normal growth in stool. Okay.
Okay.
Okay. Fine. So when do you consider when do you have to consider certain malabsorption syndromes?
Malabsorption syndrome, loose to main stool, which is bulky.
And I've already told when the growth of the child is affected. Okay, when the growth of the child is affected, then you have to consider malabsorption syndromes. So if there is a malabsorption syndrome dealing with a carbohydrate absorption, you will find that, as we mentioned, the stools will be explosive. There will be perianal excoriation. Okay. If there is fat malabsorption, the stools will be greasy and bulky stools. Okay. If there is edema along with the diarrhea, it can be a protein allergy malnutrition. Okay. What do you think about imaging? So when do you image a child with ADD or with diarrhea?
To rule out any appendicitis.
Okay.
Then if presence of abdominal distension and all.
Very good. Okay. Then. So to rule out intussusception, actually, one is to rule out intussusception. Then, if you are suspecting some Crohn's disease, inflammatory bowel disease, you definitely need an endoscopy to rule out. Okay, or for the histopathology. Okay. Okay. So which is the main preventive program that the government of India has launched to curtail diarrhea, or at least the complications of diarrhea? This programs, you should be having some idea about this. Okay, this is nothing but the IMNCI. Okay, it is the IMNCI. Okay, IMNCI. So what does IMNCI advise regarding stopping or curtailing diarrhea? It is 3F and Z. Okay, 3 F and Z. Okay, what are the 3 Fs? One is fluids, second is feeding, and 3 is follow-up. Okay, Z will obviously be
Zinc.
zinc. Yeah, zinc. So IV fluids, feeding, and follow-up. Okay, so if a child comes to you with diarrhea, you have to assess dehydration, and according to the dehydration, you have to start him on IV fluids. Or if you are sending him home, you have to give proper advice to the mother regarding his nutrition and feeding.
Okay.
Right? And you have to follow him up. Follow up if there are so-called danger signs. Right? And also you have to give zinc. Okay.
Okay.
Okay. So what is oral rehydration therapy, ORT? What is the difference between ORS and ORT?
Oral rehydration therapy may be given to prevent dehydration.
Okay.
In
so
planning.
So basically ORS is your so-called ORS solution, right? ORT is actually the administration of ORS along with home available fluids. Okay. Home available fluids. Yeah. One has mentioned sugar and salt. Yeah. Home available fluids. Okay. So that is actually giving ORT. ORT is nothing but giving ORS along with your home available fluids. Okay. So one more thing you should know before we wind up is what is the WHO 7-point planner. There is a 7-point planner from WHO for prevention of diarrhea. Okay. Do you have any idea about that? Okay, most of the things we have already discussed, but WHO has given it in a heading of 7 points. So the first thing is proper immunization of the child. Okay. Mainly rotavirus and measles vaccine. Okay, first is immunization. Second is breastfeeding. Okay, breastfeeding, which is fortified with vitamin A.
Okay.
Okay, third one is ORS and zinc. Okay, giving ORS and zinc.
Okay.
Next one is clean drinking water. Fifth one is hand washing. Sixth is safe storage of water. And seventh is community-wide sanitation programs. Okay, so these are 7-point planner for prevention of diarrhea as proposed by WHO. Okay, so first is immunization with mainly pertaining to rotavirus and measles vaccine. Second is breastfeeding with fortified vitamin A. Third is administration of ORS and zinc with diarrhea. Next is clean drinking water, hand washing, safe storage of water, and community-wide sanitation practices. Okay.
Okay.
So I think with that, we'll come to an end. If there is any doubts or anything, I'll be happy to answer.
Any doubts? I think someone is asking the doubts in the chat section.
Probiotics, yeah, probiotics. So what does actually probiotic do? So probiotics, so it has been found that you all might be probably knowing that the gut is filled with organisms, okay, microorganisms, and it is said that microorganisms, there are more microorganisms in the gut rather than more than the number of actually the individual cells. And each one of us has a unique microorganism. Okay, mine will not be same as a next person. So and also probiotics, when it comes to probiotics, actually there is all may not fit for the one size may not fit all. So that is the end of it. So what is actually happening, there is lactobacillus and Saccharomyces are the major probiotics that are being available in the market today. So as such, some studies have found that lactobacillus has some role in diarrhea, but more often than not, there are not many studies to prove it so. Yeah, role of anti-motility drugs like loperamide and all. So usually we do not advocate the use of symptomatic control of diarrhea as a rule in children, because one, it is ineffective, and second, it can be complicating as well. Yeah, Resicadotil and loperamide are not advocated or not advised in children. Reducing substances in stool usually shows the presence of some undigested carbohydrates in stool. Usually, if the child is well, because usually in an acute viral gastroenteritis, which is the most common that we encounter, there can be a transient secondary lactose intolerance, which need not be taken much into account if the child is otherwise well. But if you find that the child's weight is faltering, or the loose stools does not decrease over the maybe 5 to 7 days, you can think about stopping lactose containing foods for 1 to 2 days. Glycogen storage diseases, yes, should be ruled out. Definitely should be ruled out. But again, if the growth is faltered, if the growth is faltering, if there is hepatosplenomegaly, you can definitely think about glycogen storage disease. Also, the diarrhea usually starts from an early age, early onset. Role of antiemetics, ideally, antiemetics should not be given to a patient with diarrhea. Okay. Antiemetics has no role and ideally should not be given. It is the same as giving an anti-motility drug. Okay, antiemetic should not be given.
Any other doubts?
So even if the child has vomiting, yes. Usually antiemetics are not advocated in the line of practice. As per guidelines, antiemetics are not to be given.
Okay, sir. I think there are not much doubt remaining. So shall we wind up the session?
Yes.
Okay, sir. So myself, Dr. Sujitra, PG Coordinator, Spice Road, Kerala chapter. I would like to express my sincere gratitude to Dr. Nirmal George Naina for such an informative and well-coordinated session. Even though our title of our today's session was Navigating the Complexities of Viral Disease, I think the way in which sir approached each and every aspect of today's session was really in a simple and understandable way. Once again, thanks a lot, sir. Now coming to Dr. Megha. Dr. Megha, the way of your presentation as well as the efforts from your side was really appreciable. Thank you for such an interesting and interactive session. And next, regarding the participants for today's session, we were able to maintain a participation of more than 65 participants throughout the session. Thank you all for such a wonderful active participation from the Spice Road Kerala chapter. Once again, thank you, Dr. Nirmal George Naina and Dr. Megha.
Thank you.